Good afternoon. This is Betsy Bertelson in Spokane at Spokane Regional Health District. We're going to get started here in just a minute with our monthly Lunch and Learn webinar for Foundational Public Health Services. Today's presenter is our tuberculosis coordinator, our TB nurse, program coordinator, Katie Dickinson from SRHD. Many of you have met her, and she will give a presentation today about TB, and there will be plenty of time for questions. If anyone has questions during or afterward, please just use the little chat box, and we'll try to keep watch on that to bring up questions for Katie, and then we'll also have time at the end as well. So I'm going to turn it over to her, and if you have any technical difficulties, also let us know, and we'll connect you that way. Okay. Okay, so let's.
Good afternoon, everyone. As Betsy said, my name is Katie Dickinson, and I'm the TB program coordinator here for the TB program at the Spokane Regional Health District. And I was asked to present today on TB, and I'm going to apologize because I thought I only had 20 minutes, so this is going to be a fast presentation, and I don't go over a lot of things, but definitely we have an hour. So if you guys have questions or maybe even want to update me on what's going on in your jurisdictions, I would love to know. But we'll get started. So I always feel like just to start with kind of the basics. So what is TB? Tuberculosis is an airborne infectious disease caused by the Mycobacterium tuberculosis. We typically see TB in the lungs, which we refer to as pulmonary TB, but TB can affect other parts of the body. So if you hear a provider or someone talk about extrapulmonary, that's TB disease that's developed that's outside of the lung cavities. Transmission of TB, so TB is spread from person to person only through the air. When a person with active pulmonary TB speaks, sneezes, coughs, or sings, not everyone exposed to TB is infected, and it really does depend on 4 factors. So once you've been exposed, kind of your chances of being infected. So one is the nature of the patient's TB disease, meaning, how infectious they are, how progressed they are. Is it cavitary disease versus non-cavitary? Environment where the exposure occurred. So did your exposure occur within a small hospital room with closed doors at all time and not too much ventilation versus an outdoor exposure, maybe within an orchard here in Washington? Definitely the duration of exposure. So are you around the index case or the person with active disease every day for more than 8 hours a day, or was it only exposure? Let's say you have somebody maybe in the hospital that was just bringing in the food tray, so their exposure was less than 5 minutes. And definitely the individual or the contact risk factors, their overall health conditions, do they have any other immune compromising conditions? But all those things kind of take into play when you're thinking about those being exposed and infected. So when someone with active TB, when they cough or the bacteria into the air, the droplets are aerosolized by a person with infectious disease, and then the contact can inhale the droplets. So in theory, the larger droplets, they can stay in the nose and throat, and some maybe become trapped, and maybe infection is unlikely. But it's the smaller droplets that I've heard people talk about that travel or make their way down to the air sacs or the alveoli of the lungs, and infection occurs. So from the alveoli, a small number of the TB bacilli enter the circulatory system and spread throughout the body, contained by the immune system. And that's how people develop extrapulmonary disease. So we've had a case here with a gentleman who had TB in the brain. We just got done with treatment with a young lady from India. She had lymph node TB. We definitely see pleura a lot here in Spokane. Lungs, spine, kidneys, bone, and the larynx. So 2 to 8 weeks after the initial infection, a person's immune system contains the TB bacilli by forming a hard shell, which we refer to as a granuloma around the bacilli. And this is what makes the bacilli dormant, or what we refer to as latent TB. So once the immune system is not strong enough to contain the bacilli in this latent state, this is when someone develops active disease and the bacilli begin to multiply, allowing the TB to progress. So people always, I think, like to hear about TB on the numbers, the data for cases around the globe and states. So TB is still the 9th leading cause of death worldwide, and it's the leading cause of death from a single infectious agent, surpassing now HIV and AIDS. And we're projecting that 1/3 of the world's population is infected with the tuberculosis bacteria. So in 2016, there was 6.3 million new cases reported, 1.3 million deaths among HIV negative, and 374,000 deaths among HIV positive individuals. So your HIV positive individuals are pretty high risk once infected within that first year of infection. This is just to show you that the national kind of norms here on what we're seeing here in the U.S. So U.S.-born persons versus non-U.S.-born persons. I'll let you look over that in a little bit more detail. So if you haven't seen this, I not long ago asked the state for rates for MDR and first-line resistance. So last year, Washington State had a total of 207 active cases. We did have 4 MDR cases, and I'm not sure which county that was in, but I'd probably guess maybe King, but I could be wrong. We had 17 cases that had first-line resistance. So when we say first-line, they had at least one resistance to either isoniazid, pyrazinamide, ethambutol, or rifampin. So 9 cases were resistant to INH or isoniazid. 7 cases were resistant to pyrazinamide, or we refer to it as PZA, or 1 case with ethambutol or EMB. Spokane, I've had this program for the last almost 5 years, and it's usually pretty slow. We typically, for the last 4 years, only had 2 cases. And probably many of you have heard, we've had a pretty busy year. So as of today, we had 10 cases to date for this year. 6 of our cases were pulmonary, 4 of them were extrapulmonary, and we haven't had, knock on wood, any MDR cases yet. And then our countries of origin for these cases are Philippines, Republic of the Marshall Islands, Kenya, Vietnam, and Thailand. I wanted to, if anybody online is new to TB, I definitely wanted to offer some resources for trainings, education, and consultation resources. So I don't know if you've heard, hopefully all of you have heard about TB Project Echo. It's held every Monday, which we're overlapping with it today. But they provide medical education and case consultation to clinicians, pretty much anybody who's screening or managing LTBI or active disease. So this is a great resource. Like I said, it's once a week. They do offer continuing education credits, and it's usually video conferencing, but if you don't have access to video, you can just phone in and listen or present a case. You do have to go through the Washington Department of Health TB Program's website and fill out a form. If you have any question, they make you fill out a form and put your question on there, or case issues or how to manage whatever question you may have. You have to fill out a form. So you have to go on this link. It's pretty easy to navigate the form. But if you have any questions, I would recommend that you get a hold of Lana K. Tyers, the Washington nurse consultant, and she'd be more than happy to walk you through the forms. If you haven't heard of the Curry International TB Center, this is also a great resource for training. I would highly recommend attending one of their in-person trainings, but I know some of these smaller jurisdictions don't have the money to send staff. So the good thing is they have a lot of trainings, a lot of products all online, and you can actually order stuff online. It's all free, or you can just look on it online as well. But I would definitely recommend, if you're new to case managing TB or LTBI, to get on the Curry's website and take a look at all the products that they have, especially this new nursing guide to managing side effects to drug-resistant TB treatment. Even though it says drug-resistant, I think it's a pretty good product for anybody who's on any TB meds, especially who are experiencing side effects. This is a really great resource and gives a lot of great information on ways to manage those side effects. But I would definitely recommend taking a look at that. WTCN is the Washington TB Collaborative Network, who has been a great help to us this last year with one of our larger investigations that we had. Our TB program at the time only consisted of myself and Dr. Lutz, so we were looking at screening around close to 200 people, and for one person to do that is a lot of work. And so we contacted Dr. Masanarita and his group here at WTCN, and they were able to provide us consultation and actually send over staff to help us provide 2 screening events within this investigation. And I can't speak highly enough. These guys are a really great resource. So if you find yourself as the lone soldier out there in your jurisdiction and you have a bigger investigation that you feel like you need help with, I would highly recommend contacting WTCN for any questions, consultation, educational material. They are a great resource. This is just their flyer, but their phone number and email address is listed above there as well. So if you aren't already aware of this, but I just wanted to bring it up, most of the labs, I think just about everybody has switched over from using the QuantiFERON TB Gold to the QuantiFERON-TB Plus test. The real main difference is, well, one, there's an extra tube. So they've added an extra tube that stimulates additional CD8 T cell stimulation, which is important. I guess they're starting to see more research. They see more of the CD8 T cells activated in TB disease. But it's supposed to help maybe determine whether this is a new exposure versus an old exposure. So maybe somebody that you're screening in an investigation, it can maybe tell you whether their infection is an old infection or this is a true new infection from your contact investigation. They usually see this CD8 T cell activity more detectable in active TB patients with HIV co-infection and in younger children. And they usually, I guess, we're seeing it decline in patients who are exposed to tuberculosis therapies. I am by no means an expert in this test, but I would definitely recommend getting on Qiagen's website. They're the manufacturer of this test, and taking a look. They have some great videos you can watch that kind of explain it in a little bit more detail. But if you aren't familiar, I'm not sure. I'm pretty sure all the labs have rolled this out. It's something to be aware of. So still the big push, and after going to the TB conference within the last 2 weeks, it's still a big push for more people to get on latent TB treatment, because there's an estimated 10 to 15 million people infected with the TB bacteria, and roughly 85% of those active cases are due to reactivation of their infection. So meaning someone's been infected and now they've progressed to active disease. And I can only speak for the cases here, but I think pretty much all of our active cases were probably once infected with latent TB and never went on treatment. And pretty much all of them have other comorbidities, primarily either hepatitis or diabetes. So their immune systems are compromised, and then it leads into their development of active disease. So the new recommendations, if you weren't able to attend the conference a few weeks ago, Dr. Lindquist and all the other experts are really recommending shorter LTBI regimens. So the 3HP is the once-a-week regimen using isoniazid and rifapentine, or the daily rifampin for 4 months, given concerns of INH-related hepatotoxicity with INH for 9 months. Individuals' poor adherence due to longer durations. So we're seeing people complete treatment better with these shorter courses than 9 months of INH. And of course, there's an increasing proportion of patients from TB endemic countries with INH resistance. Unfortunately, I wasn't able to show you these, but the Department of Health TB website has these posted. They still have some information posted on the conference, and that's the only, you'll have to go on there and look for the conference information. And I'm sure that DOH will put this in another location, but they have a really great full-page guidance document. It's a PDF document that goes over all the regimens, these shorter course regimens, and it's guidance for patient education before and after, and it goes through each regimen in detail. So if you're not familiar with these regimens, I would highly recommend taking a look at the full guidance document. This would also be a great resource for any of your local providers who are managing latent TB. I don't know if you guys are in your jurisdiction, but we're only managing latent TB for known contacts. So I've been faxing this out or handing it out to our local providers to take a look at. I don't know if they actually read it, so then you can give them this one-pager, which is a really nice, just quick handout. It's condensed of all the regimens, and it goes through dosage, the recommended dosages for adults and children, and then other contraindications for physicians to think about. So these are great resources that just came out within the last 2 weeks for Washington Department of Health TB recommendations for latent TB. I wanted to just speak a little bit about patient education material in multiple languages. I think pretty much all of our patients here in Spokane do not speak English, so I think this is my own personal opinion, and maybe you guys have other resources that you prefer to go to, but I absolutely love the Minnesota Department of Health's website. They have an extensive amount of fact sheets. They have new posters. They actually have some even videos in multiple languages for sputum collection, which I found to be probably the most challenging thing to try and explain to someone who doesn't speak English how to collect sputum. Those videos are really, really good. But there's a link to their website there. And then the Massachusetts Department of Health also has multiple language material, but I feel like their material, which is still good, but it's more geared toward LTBI adherence and diagnosis, but also a great resource. Our contact information is here, my work cell phone number, so if anybody had questions or needed assistance, please feel free to call me on my work cell. But like I said, Dr. Robert Lutz is our health officer here. Myself, Kira Lewis is a part-time nurse that we just hired. And then Tarway is, we just hired her as well, but she's a Marshallese community outreach worker who we're really excited to have on board. Spokane has a large growing population of Marshallese individuals who we've been told is larger than 5,000 individuals. So our last 2 major contacts investigations were within the Marshallese population. So it was something that I felt like we need to get on board as a resource for our program. So my apologies again. I talk really fast and it's only been 15 minutes and we have the full hour. So if anybody has any questions or would like, whoops.
No, that's fine.
Would like to add any comments about, things they're seeing in their jurisdictions, I would love to hear about that.